Hi, I'm Justine Burke.
Hi, I'm Lance Simard,
Welcome to the Pharma Files.
where medicine meets mystery.
We're going to drop you right into a specific time and place this morning. It's a scene that, to a modern ear, it's going to sound like something from a medical thriller.
Or a horror movie, really.
Yeah, but for 2 decades in the 20th century, this was just Tuesday. We're in the mid-1930s. The time is 6:15 a.m.
And the ward is just starting to stir. We're inside a leading psychiatric hospital, and they're practicing what was considered the most cutting-edge treatment available.
The whole scene it's deliberately quiet. It's
Yeah.
governed by this really rigid clinical choreography.
You can almost hear it. The night nurse handing over the clipboard to the morning shift, detailing the vitals, the notes on behavior.
And the orderlies are moving with this, almost military precision, checking each patient pupils, respiration, pulse.
It's all about control, or at least the appearance of control over a procedure that is, well, inherently out of control.
And the first sign that this day is different, that something profound is about to happen, is the absence of breakfast.
Right, and that's crucial. The whole goal of the morning is to starve the body of energy.
Food would interfere.
It would completely interfere with the metabolic disruption they're about to initiate. So the patients are fasting, just lying there waiting for this deliberate descent into unconsciousness.
And out of all these silent patients, our focus lands on one. Harold, in bed 12.
He's a young man, only 23. He was admitted about 8 months ago after what the records just tersely call a rapid unraveling.
Before his diagnosis of schizophrenia, before the fragmented speech and the voices, he was just a shipping clerk.
He's that link to a normal life. His mother still brings him clean socks every Sunday.
And Harold isn't new to this. Today is his 9th insulin treatment.
And the doctors have been methodically increasing the dose all week, just tightening that physiological tightrope he has to walk. They're trying to find the exact dose required to push him right to the edge.
A nurse approaches his bed. She's preparing this large syringe, sort of hiding it behind the medication cart.
Maintaining that clinical distance, the patient becomes a subject.
The anticipation must be just palpable. For the staff who are watching the clock and for Harold lying there, they know how fast this is going to unfold.
They do. They did it yesterday. He lost consciousness in under 40 minutes, which, disturbingly, this supervising physician actually logged in the chart as a good sign.
The injection itself is brief, a cold sting, a burn.
But the collapse that follows is terrifyingly rapid. Within minutes, Harold is drenched in sweat. His hands start to tremble uncontrollably against the sheets.
And there's this immediate internal fog. It's not just psychological confusion. It's a raw, dizzying inability to process anything.
Any attempt to speak just dissolves into slurred sounds. The nurse is wiping his forehead, muttering reassurances. But you have to remember she has 6 other patients going through this exact same thing right down the ward.
The observations continue, minute by minute, all logged on the chart. His pulse quickens as his body desperately tries to compensate.
His breathing gets shallow, his eyes drift closed. And then at 42 minutes, and they stamp the time precisely, Harold slips past stupor and into a deep coma.
And this isn't sleep.
Not at all. This is a profound metabolic crisis.
For the next hour, his body is, it's essentially a machine under rigorous real-time observation.
Everything is charted. Muscle tone, deep tendon reflexes, every little shift in his breathing.
They're looking for that precise moment, that window between the supposed therapeutic benefit and, irreversible brain damage.
And to show you the risk they were running, you hear this chilling detail. Down the row, another patient has a brief but violent seizure.
Staff rush over, stabilize him, but there's no panic.
No, because the protocols are so defined and the stress they're inducing is so severe that this extreme reaction is just recorded, impassively, as expected.
That one word, expected, that tells you everything about the accepted risks of this therapy. It's an incredible tightrope they were walking.
Balancing between a violent expected reaction and, death or permanent brain injury.
And then the time is up. The physician gives the signal. The rescue begins.
And glucose is administered, not gently, but forced through a nasogastric tube. It's a rush of sugar to reverse the shock.
Slowly, violently, his body starts to wake up. He stirs, his eyes flutter open.
And the immediate result of that trauma is he vomits, he coughs, and then just completely depleted, he drifts back into a shallow sleep.
He'll be awake by the afternoon, exhausted, disoriented, numb, but alive.
And here's the really unsettling part.
They're going to do it all again tomorrow. This whole harrowing, life-threatening cycle was not considered reckless. It was considered the pinnacle of modern scientific psychiatric care.
And that really is the context for our conversation today. How insulin coma therapy, or ICT, went from this obscure observation to a global standard of treatment.
It's just genuinely shocking. I mean, how did medicine, a field that's supposed to be rooted in first do no harm, get to a point where intentionally inducing a life-threatening coma was the progressive answer?
That desperation came directly from the reality of institutional psychiatry in the early 20th century. The field was in a total state of crisis.
Overcrowding.
Massive overcrowding. You're talking about huge public asylums that were just bursting at the seams with patients suffering from these intractable conditions: schizophrenia, chronic mania, severe depression.
And most of them were there for years,
Right.
for life.
For life. And the physicians, their professional toolbox was essentially empty. They had almost nothing effective to offer.
Beyond, what, physical restraint?
Physical restraint, crude sedation, and what they called custodial care. They were managing behavior, maintaining order, but they weren't changing the disease. Recovery was completely unpredictable. It was more about luck than any medical intervention.
And the big intellectual theories of the time weren't helping either.
Not at all. Psychoanalysis was gaining a lot of intellectual cachet, but it required stability, time, verbal engagement.
Things that were totally unavailable to a severely psychotic, institutionalized patient.
Exactly. It was completely impractical for mass asylum care. And neurology, the other discipline looking at the brain, was just as limited.
They were just descriptive.
Purely descriptive. They could see brain damage after a patient died, but the living brain's function was a total black box. Neurotransmitters like dopamine and serotonin, unknown concepts.
So psychiatry was just stuck in this miserable limbo.
An uneasy middle ground, yeah. And they were under intense pressure from the rest of medicine to demonstrate some kind of scientific legitimacy.
So if you can't reach the mind through reason, the conclusion was, you have to force the body.
It was a massive, desperate pivot. They started exploring everything, generating seizures with electricity, with chemicals, or creating profound metabolic disruptions, like ICT.
And the guiding assumption was incredibly crude, but you can see the appeal.
The idea was that extreme physiological stress, a shock, might somehow reset the brain, violently interrupt those rigid pathological patterns of psychosis.
And the key attraction for the doctors, for the administrators, was that these interventions, unlike talking, were dramatic, visible, and crucially measurable.
Absolutely. You could time a seizure to the second. You could calculate a precise dose. You could log the exact moment of collapse. ICT fit perfectly into that. It used metabolic manipulation, driving blood sugar dangerously low to induce coma.
And again, the fact that this procedure, which was a hair's breadth from a fatality, was standard is what's so stunning.
It was. For nearly 2 decades, from the early 1930s to the early 50s, ICT wasn't a fringe experiment. It was modern, routine, and scientifically ambitious practice in leading psychiatric hospitals all over the world. It was the best they thought they had.
So where did this idea even come from? We have to look at the man behind it, Manfred Sackl. Where did he get the idea that insulin could cure schizophrenia?
He stumbled upon it, really, completely by accident. In the late 1920s, he was working with morphine-dependent patients.
Nothing to do with psychosis?
Nothing. He was using small doses of insulin because it was known to stimulate appetite and help patients gain weight, which was important for these often malnourished addicts.
So he's using it for a purely physical, supportive reason, and he sees a behavioral side effect.
Yes. And the observation was, well, it was thin, almost anecdotal. He just noticed that some of these patients, after their insulin dose, seemed calmer, a little less agitated.
So a very subtle signal.
Incredibly subtle. Under normal scientific scrutiny, it probably would have been dismissed as insignificant. But you have to remember the therapeutic vacuum of the time. Any signal of hope, no matter how vague, was seized upon as potentially revolutionary.
And that faint signal was enough for him to build this huge, ambitious hypothesis on.
It was. He speculated that if insulin had this effect on the body's metabolism, it must therefore be influencing brain function. He started framing psychosis not as a psychological issue, but as a disorder rooted in disordered biology.
And that led him to a pretty aggressive line of logic.
Extremely aggressive. The thinking was, if a small, supportive dose has a subtle calming effect, then a massive, deliberately dangerous physiological disturbance, a coma, might produce a decisive transformative cure.
Wow, that's quite a leap. And it led directly to that protocol we saw Harold enduring. So who were the primary targets for this?
Primarily patients diagnosed with schizophrenia, especially those in the acute or early phase. The treatment was a course of progressive escalation. Every day, a slightly higher dose of insulin, forcing the body to burn through its glucose.
And it wasn't a simple on-off switch from conscious to unconscious, was it? It was a very defined, terrifying progression.
A monitored descent, absolutely. First stage, hypoglycemia kicks in, intense sweating, tremors, confusion.
Yeah.
Then, as the blood sugar plummets, you get to stage 2, profound confusion, dizziness. Then stage 3, slurred speech, stupor. And finally, the goal, deep hypoglycemic coma.
And they wouldn't rescue the patient right away. The duration of the coma was seen as part of the therapy.
That's the critical part. They'd hold them in that coma, sometimes for up to an hour, right on that razor's edge between therapeutic benefit and irreversible brain damage. Only then were they revived, aggressively, with concentrated glucose through a tube.
And this cycle was repeated how often?
5 or 6 times a week, for courses that could last for weeks, even months.
It sounds like sustained, systematic physiological violence. So what was the clinical language, the rationale they used to justify this?
The language was all borrowed from the growing field of shock therapy. The general idea was that any kind of shock, electrical, chemical, metabolic, disrupts pathological brain activity. It achieves a reset.
And Sokal added this layer of supposed biological sophistication, the selective damage claim.
He did, and this was absolutely crucial for selling the therapy to the medical establishment. He argued that ICT selectively damaged only the diseased neural circuits, the parts causing the psychosis, while somehow sparing the healthy tissue.
A kind of biological pruning.
That was the idea. He used all the authoritative language of neurology, talking about localized damage and repair, but without a single shred of verifiable evidence.
But the aesthetics of it, the appearance of science, that must have been irresistible for a field so desperate for legitimacy.
It was the perfect storm. Psychiatry was always being criticized for being vague and subjective. ICT gave them structure, rigor, numbers. You could measure blood sugar. You could calculate doses. You could time comas to the minute. It gave them the tangible appearance of biological precision and control.
That structure was probably more compelling than any real proof of a cure.
Arguably, yes.
Let's dig into the mechanics of insulin itself, because the drug already had this immense authority, which must have helped legitimize the whole procedure.
Absolutely. The authority didn't come from psychiatry. It came from physiology. Insulin was a true miracle drug of the 1920s. It had turned type 1 diabetes from a death sentence into a manageable condition. Everyone respected its power.
So the basic physiological fact is that insulin lowers blood sugar. An overdose, then, was effectively just starving the patient's brain of energy.
That's the core mechanism. The brain is ravenous for energy. It needs a constant supply of glucose. When you cut that supply with a massive insulin dose, the brain goes into crisis mode. That's what causes the progression. Confusion, tremors, loss of consciousness, and, if you go too far, permanent damage or death.
And that extreme, visible vulnerability of the brain was somehow interpreted as a therapeutic opportunity.
It was, and it tied into the way they were starting to see mental illness as a disorder of brain function, not a moral failing. The problem was they had no tools to actually see that function. They couldn't image neural circuits or measure neurotransmitters.
So if they couldn't measure the brain's chemistry, they measured its metabolism instead.
Precisely. Blood sugar gave them tangible, adjustable numbers. And the hypothesis was that by forcing the brain into this controlled biological crisis, this metabolic shutdown, normal function, would somehow reemerge when they rescued the patient. The brain would be reorganized or reset.
But let's go back to that central, critical claim, the selective damage myth. The idea that the sick part of the brain was somehow more fragile, it's just startling.
It was the heart of the whole theory, and it gave the therapy intellectual cover. The idea that pathological brain tissue was selectively sensitive to stress, that the insulin shock was just pruning away the psychosis. And again, there is zero direct evidence for this. It was pure assertion, just borrowing the language of neurology.
And when you contrast that with what we know now from modern neurobiology,
it's completely different. Modern neuroscience shows that hypoglycemia affects the brain globally, indiscriminately. It doesn't target diseased parts. In fact, the areas with the highest metabolic demand, like the hippocampus, which is crucial for memory, are often the most vulnerable.
Which would explain the lasting cognitive impairment and memory problems in ICT survivors.
It provides a very strong explanation for it, yes.
Yep.
So the improvements they saw, the calmness, the reduced agitation, weren't signs of a cure.
They were signs of trauma.
Far more likely, yes. The non-specific consequences of profound physiological trauma. If you go through a near-fatal metabolic shock, 5 days a week for 6 weeks, you're going to be exhausted, sedated, confused, and very, very compliant.
It's still hard to fathom how this flawed theory lasted for 2 decades. Why did the medical community stick with it so long if the science was so weak?
There were a few things that really cemented its longevity. First, just observational bias. The clinicians saw calmer patients and interpreted that as a therapeutic success, not as post-trauma sedation. They saw what they desperately wanted to see.
And then there's that classic logical fallacy: correlation is not causation.
Exactly, the trap of post hoc ergo propter hoc. After this, therefore, because of this, if a patient got better after the coma treatment, they assumed the coma caused the improvement.
And if the patient relapsed,
The system had a built-in excuse. It wasn't the therapy that failed. It was the severity of the underlying disease that was just too strong. The theory could explain away both success and failure.
and it all comes back to professional credibility.
It does. This biological framing separated them from the perceived softness of psychoanalysis. It produced charts, numbers, protocols. The biology was real. The effects were real. The leap from metabolic disruption to psychiatric cure, that's where the evidence was then, but it felt reasonable enough at the time to sustain it.
So given they had this dangerous but measurable technique, how did they pick the patients? They obviously didn't give it to everyone in the asylum.
No, and they used a very specific selection bias. They focused almost entirely on patients with early or acute schizophrenia. This was absolutely crucial for maintaining belief in its effectiveness.
Why the acute patients?
For a few reasons, both medical and institutional. First, that group of patients was just statistically more likely to show some spontaneous improvement anyway, regardless of what you did.
Right. They might respond to just being in a structured environment.
Exactly. The intensive care being removed from stressors. And when that improvement happened, the doctors could confidently point to the insulin and say, see, it works. It created this powerful, self-reinforcing narrative of success.
And practically, it just managed institutional risk. Treating chronic patients who didn't get better would have been a PR nightmare.
A huge reputational risk. If a patient who'd been institutionalized for years failed to respond after weeks of comas, it would raise very uncomfortable questions. But an acute patient who was admitted, treated, and discharged, even if they relapsed later, that was a clean, publishable success story.
And the optics for the families must have been better.
Much better. Families of newly diagnosed patients were desperate to halt the disease, so they were more likely to consent to this aggressive measure. The doctors could frame it as a definitive, all-out effort.
So they were basically skewing the data pool from the start to maximize the chances of a win.
That's a good way to put it. Those high success rates you see cited, 50 to 70%, they were coming almost exclusively from the patient population most likely to improve anyway. It was a statistical filtering process that was never really challenged.
And the shift from a speculative idea to a core institutional routine happened incredibly fast.
It was alarmingly rapid. By the early 1930s, ICT was spreading across continents, promoted heavily in conferences and journals. And major hospitals didn't just try it out. They invested huge resources to build dedicated insulin units.
So these weren't just improvised rooms.
Not at all. These were highly organized, complex clinical spaces. They had specialized monitoring equipment, huge supplies of emergency glucose, oxygen tanks, meticulously enforced protocols. It was a massive logistical undertaking.
And the sheer amount of labor required must have been staggering.
Immense. The treatment demanded extremely high staff-to-patient ratios. You needed nurses at the bedside, continuously, for hours, monitoring those subtle shifts. The timing of the rescue was unforgiving. And ironically, that very complexity reinforced its legitimacy.
The fact that it was difficult and expensive made it seem more serious and respectable.
Precisely. It signaled that this was controlled, technical, specialized medicine, the exact opposite of the chaotic custodial care in most asylums. And the published narratives, those high success rates, they just amplified this image of dramatic reversals.
And the hospitals could really capitalize on that.
Enormously. Offering ICT was a huge value proposition. It signaled that your asylum was a modern, progressive medical center. They used these insulin units as centerpieces in fundraising campaigns.
But the data was just fundamentally flawed. They were filtering the patients and filtering the results.
They were. The definition of improvement was totally subjective. Long-term follow-up was almost never done. And critically, patients who failed to respond were often just quietly excluded from the published statistics.
And what about when patients died?
The deaths were minimized. They were rationalized. Fatalities were often attributed to complications of the existing illness, meaning schizophrenia, rather than the treatment itself. In that era, Institutional enthusiasm just steamrolled the need for rigorous data. Speculation hardened into routine care based on momentum, not evidence.
It's clear the institutions were driving this, but public perception had to be a huge factor. There was so much faith in medical progress back then.
That faith was critical. The 1930s were full of medical promise, but psychiatry was the field lagging behind. ICT offered hope wrapped in scientific action. It was an active, physiological intervention.
For the families, it must have been an agonizing kind of relief.
Immense relief. For relatives watching a loved one disappear into psychosis, ICT was the only visible lifeline. When they were asked for consent, doctors stressed the urgency, the science, the narrow window of opportunity. The extraordinary risks were accepted because the alternative felt like permanent confinement.
And the media played a role in framing it as a breakthrough.
A crucial role. Newspapers and hospital press releases were full of these dramatic success stories of patients restored. The dangers were framed as necessary, manageable risks, an acceptable price for a potential cure.
In the language itself, the euphemisms, they seem designed to hide the reality of it.
The euphemisms were central. Controlled hypoglycemia, coma therapy. It sounds so clinical and authoritative. It hides the brutality of what was happening on the ward. The seizures, the vomiting, the patient lying on the edge of death for an hour. This managed narrative fueled public trust and, critically, helped the institutions raise funds and build prestige.
But none of this routine, none of this control was possible without one enormous, often invisible component: the nurses.
That is the profound and often omitted truth of ICT. It was framed as a physician-led breakthrough, but it was sustained entirely by relentless nursing labor. Without constant, highly skilled, moment-to-moment bedside monitoring, the mortality rates would have been astronomically higher.
What were their specific tasks? It sounds like they were human vital sign monitors.
They had to be expert observers of the most subtle shifts, tracking minute changes in skin temperature, breathing patterns, muscle tone. They were the ones timing the coma, preparing the emergency glucose, managing the patient's panic, cleaning up the vomit.
And the margin for error was terrifyingly thin.
It's non-existent. A delay of a few minutes in spotting a crisis or giving the glucose could mean irreversible brain damage or death. Yet, all this responsibility was decoupled from formal authority. The nurses were the first to recognize a crisis, but the final decision often rested with a physician who might not even be at the bedside.
And this critical, intense labor was just erased from the official medical narratives.
Completely erased. The published papers focused on the doctor's dosing schedule and the outcome stats. The immense physical and emotional demands on the nursing staff were just ignored. That labor was just framed as evidence of the therapy's rigor, not the core skill set that was actually keeping patients alive.
That's such a profound injustice. They were the last line of defense against permanent damage, yet the credit, the prestige, all flowed upward to the physicians.
It's a powerful metaphor for how these things work. Success validated the physician's theory, while the vigilance of the nurses, which compensated for the inherent danger of that theory, was just never properly acknowledged.
To really understand how that narrative was built, let's look at a typical case report from that time. How did they sanitize the experience?
These reports were masterfully constructed to persuade. They always detailed the patient's decline, meticulously outlined the technical treatment protocols, and then presented the outcomes in the most optimistic light possible.
Tell us about that case you mentioned, that 26-year-old woman.
She was admitted with an acute schizophrenic reaction, paranoia, withdrawal, incoherent speech. After standard care failed, she was moved to the ICT unit. The report emphasizes the careful dose escalation. By the 6th session, coma was reliably induced.
And what did the report say about side effects?
It noted the highly disturbing detail of occasional seizure activity, but then immediately downplayed it as being within expected limits. After about 12 treatments, the clinicians noted she was becoming quieter, more cooperative. After 20 treatments, she was classified as oriented and cooperative.
And discharged as a victory.
A total victory. The classification was marked improvement. But here's the crucial omission. The report gives no detail on whether her core delusions were gone, whether she could function socially, or if the improvement even lasted. Long-term follow-up was almost always absent from these reports.
So improvement often just meant the patient was easier to manage.
That was often the functional definition, yes. Reduced agitation, increased compliance. If the patient was easier to handle in hospital, it was recorded as a success. And if they deteriorated later, well, that was the fault of the disease, never the treatment.
And the ultimate failure, a patient's death, was just managed through euphemism.
Tragically, yes. If a patient died, they rarely had a critical discussion about a miscalculated dose or a delayed rescue. They simply recorded that the patient succumbed during treatment. These case studies were advocacy pieces, designed to convince everyone that psychiatry had finally found its silver bullet.
Let's talk about the collapse then. It had to be rooted in how fragile that evidence was. Just how flawed was the data supporting ICT?
By modern standards, the data was non-existent. This was an era before randomized controlled trials, or RCTs. There were no blinded evaluations, so the doctor giving the treatment was also judging the outcome. That's a massive inherent bias.
And the effect of all that intensive structured care was just ignored as a variable.
Completely ignored. We know today that just providing that level of care can stabilize patients, and the lack of long-term follow-up meant that these temporary, environmentally induced improvements were published as genuine therapeutic wins.
But regardless of the data, the physical risks were undeniable. You mentioned a mortality rate of 1 to 5%.
The risks were profound. They were intentionally inducing a state-severe hypoglycemia that we consider an acute medical emergency. To accept a 1 to 5% mortality rate for any procedure today would be, well, it would be unthinkable.
And the ethical safeguards were just absent.
The framework wasn't there. Many patients were involuntarily committed, incapable of giving informed consent. Families were told this was the only hope. In these overwhelmed institutions, the willingness to accept near-fatal risks became tragically normalized.
So when did the professional resistance finally start to break through this wall of certainty?
The first cracks started to appear in the late 1940s, mainly because of a competing shock treatment, electroconvulsive therapy, or ECT. ECT had a similar perceived effect, but it was far easier and cheaper to administer. Lower staffing levels, no dedicated unit, and critically, you weren't pushing the patient to the brink of a metabolic catastrophe. It offered a similar reward with a lower immediate risk.
So ECT challenged it on logistics and risk, but the decisive blow wasn't another shock therapy, it was the revolution in pharmacology.
Absolutely. The game changer was the arrival of the first antipsychotic medications in the early 1950s, especially chlorpromazine. Right. This drug offered something completely new. Reliable symptom control, a genuine reduction in psychosis, achieved through chemistry, without nearly killing the patient. It did safely what insulin was supposed to be doing through brute force.
Once that pill was available, the entire risk-reward calculation for ICT became indefensible.
Precisely. And when rigorous comparative studies were finally done, the kind of studies that should have been done 20 years earlier, ICT was found to perform no better than just supportive custodial care. The great breakthrough was finally revealed to be what one review called an elaborate illusion.
And yet, even with the proof of ineffectiveness and the obvious risks, it still took time for hospitals to abandon it, that institutional inertia.
Inertia is a massive force. By the 1940s, hospitals had invested huge amounts of money in these dedicated insulin units. They'd trained entire cohorts of staff. The protocols were deeply embedded.
It's the ultimate sunk cost fallacy, but with human lives.
That's exactly it. To abandon ICT meant a profound, institution-wide admission that years of intense labor, resources, and patient deaths had been dedicated to a deeply flawed approach. That is an incredibly difficult thing for any medical institution to face.
And the professional reputations built on this therapy must have fought its decline.
Oh, absolutely. Senior physicians had built their careers and their authority on mastering and defending ICT. To challenge the therapy was to challenge them directly. They resisted discarding this dangerous tool until the antipsychotics were so widely adopted that the justification for ICT just became impossible to defend.
So its longevity was really a testament to institutional momentum, not effectiveness.
Exactly. So as we close this, the legacy of insulin coma therapy it's uneasy, but it's really instructive. It's a profound cautionary chapter in the history of medicine.
It shows how easily the field can mistake sheer intensity and drama for actual efficacy.
In the 1930s, inducing a coma, charting blood sugar, timing the rescue, it felt like powerful, controllable action in the face of complete helplessness. It filled the wards with routine and a sense of purpose.
And today, ICT survives as this stark reminder that our standards of care are shaped by urgency and institutional momentum, not just by pure evidence.
And we have to remember, the clinicians doing this weren't malicious. They were professionals working within the limits of their knowledge, genuinely convinced that the extreme risks were justified because, at that moment, they truly believed there was no better option to fight the darkness of psychosis.
It's a sobering thought, really, that sometimes the most dangerous therapies aren't born from recklessness, but from certainty. Meticulously practiced every day until the moment medicine finally learns enough to stop. And expert speaker, until next time.